My name is Jerry Zion. I am the Global Training Manager for Fluke Biomedical. Actually, we're calling ourselves Fluke Health Solutions now. And we are an independent operating company under the big parent Fortive. We used to be a division of Fluke. And we are now our own operating company. So just to give you a little background and help you stay up to speed on the players, got to have a scorecard, right? So that's who we are. I'm happy to be here. Thank you all for taking the time this morning to spend a little time with us. We're going to have more of a discussion rather than a talking head about vital sign monitors, patient monitors. What are those parameters? Why should we test them? Where should we expect failures to happen? And what happens if we have a failure during clinical use? And I'm interested in hearing your experiences as we walk down through this kind of parameter by parameter. I have my own, but mine are a ways back these days, except where I get to experience them with you when I happen to be able to be out with you, working, coattailing with you in the hospital or the medical facility that you're covering for that period of time. So without further ado, let's get going. No. All right, we're gonna work through our technical difficulty here really quick and then we'll get going. First of all, have any of you or your department collectively decided that you're not gonna test patient monitors anymore? Please raise your hand if you've made that decision. Now, why do I ask that? What has been your experience with patient monitors, reliability-wise? Do they do what they're supposed to do pretty much? When you do your preventive maintenance on them, do you find like not very many failures in the monitor itself? What's been your experience? Right, where are the failures happening? Outside the monitor, so it's in the sensor, right? It's in the part that connects to the patient. Because the wear and tear of those are single patient use usually these days. And there's where we can expect to have the biggest part of our problems. Nevertheless, they do participate in the accuracy of the measurement and the repeatability of the measurement. So we'll talk a little bit more about that as we go through. So purpose of patient monitoring, we're just going to review that together. I'm sure all of you know what that is. What can go wrong? As I said, we're going to take a look at that, and then some close-ups on specific vital sign parameters. Starting with the basics, the intended use. So this is a US FDA term, right? The intended use of the device. Patient monitors intended at a high level for diagnosis and then for monitoring of the treatment program, whatever the doctor has decided is going to be the treatment. And so it plays both those really important roles. So if the measurements that are made using the patient monitor are not accurate or not reliable, what's going to happen to the diagnosis? How about, let's just talk about blood pressure for a minute, and we'll get into a deeper detail about that afterwards. Let's just talk about blood pressure for a minute. What if the measurement of blood pressure is too high or too low compared to what's real? And how will a clinician know? Right? The doctor or the nurse is going to base what they see and what they hear and what they feel on their experience up until that point. with the whole range of patients that they've ever treated. Old patients, young patients, baby patients, adult patients, obese patients, the whole range, okay? And I'm telling you, they kind of don't know. So how often are we going to test patient monitors? Doctor, how often do you test them? Once a year? Anybody else testing them more often than that? 2 times a year? And what was the basis for your decision on that? Their requirement. So is that under Joint Commission or something? Okay. Okay. All right. So they're a client for your company, right? Okay, that's fair. And we can talk a little bit about that because one of the things we teach is a risk-based assessment of how often we should do testing on any medical device. And we got a really good way to do that from a worksheet that you can download and fill in from the University of Vermont, who was the author of our Medical Equipment Quality Assurance Program Development and Procedures textbook that we teach from. So that risk-based assessment usually comes up with the once per year. But based on how the care and feeding, the wear and tear of that particular category of medical device happens in the facility that you're serving or the client's locations, you may come up with the same idea that you need to test more often, and you're allowed to do that. Of course, now, thankfully, since 2012, when we had the CMMS trying to tell us how to do our jobs, we now understand that we can do an alternative program, but it has to be based on real data. So you need to be collecting data. You need to know what your failure rates are in particular, okay? And we have another session later tomorrow that you're going to want to go to about, it's a demonstration of a new workflow automation software that we provide and how we do all of that to help you get those failures and move them effectively into your database, your CMMS. All right. Now, okay. So make correct diagnosis and evaluate the effectiveness of treatment. That's the high-level intended use of patient monitors. Let's just consider that we might divide patient monitors, which is a really big category, from a single patient, a single vital sign like a pulse oximeter only, to 2 or 3 vital sign parameters like we might have in a triage unit where we might have temperature, blood pressure, and cuff blood pressure, and oximetry, right? To these levels. So we call basic, advanced, specialty. Specialty being like those surgery centers, something in the OR, something in the high-end high acuity ICU, right? Something at a ventilator bed, all right? Something like that. Or specialty like, how about fetal maternal monitoring for delivery room, okay? So we can talk about those kinds of things. So just consider kind of the different categories there. So what could go wrong? Our research shows, reported to the FDA for oximetry and cuff blood pressure and IBP alone, in the United States alone, we have 400 plus adverse events in any given year. Any given year. And you can go on US FDA website and you can see the incident reports for each, for these kinds of categories. Go look at it yourself. Don't just trust what I'm telling you. What can go wrong? In this case, the blood pressure was overestimated by just 5 millimeters of mercury, but that could lead to an inappropriate treatment with hypertension medications in almost 30 million Americans who suffer from high blood pressure where it needs to be treated. I'm one of those. Anybody else? Okay, HIPAA is going to apply here and nobody's going to share that. But so you know then how important it is that you are getting the proper prescription and that you're getting it on time and what it does to you physiologically and how it helps you control your blood pressure, right? So this is important. Yeah, okay. So let's take a little bit of a deeper look, more specifically, vital sign parameter by vital sign parameter. Let's start with temperature. Why do we monitor temperature clinically? Yeah, to help identify disease states. So here's the kind of thing that can happen. We don't just, I mean, we do take the patient's temperature as part of triage when they come into the urgent care or when they come into the ER. We're going to measure their temperature. The reason we do that is not just to see if they have a fever, not just because we've just come through a COVID pandemic where temperature was the big vital sign that told us a lot about what we should be doing quickly for patients with the virus, right? But it's even more important than that, because for patients in the hospital already, or patients who come to the hospital with viral and bacterial infections, that sepsis, the key and initial indicator is the spike in temperature. So likewise, in the emergency room and in our first responder areas of, so like ambulance services and so forth, we are going to treat patients with hypothermia. They've been out and exposed to the weather, maybe they've been in cold water, and so their physiologic performance is suffering because their body and their central nervous system, the brain, is cold and it just can't function very well. So the two ends of the spectrum, both low temperature and high temperature, become really critical for us to find and properly diagnose these kinds of situations. We may have a sense in general that the patient is cold and therefore we want to make the temperature measurement. We may have a sense that the patient has got a high fever. We can feel that, but we can't tell how high. So how high or how low is important. Are you hearing accuracy in that? The importance of accuracy? Okay, so it is important that we test more than one temperature setting and make sure that it is accurate within the accepted tolerances, right? What are those tolerances? Where do they come from? They come from international standards, and even the AMI-ANSI standards, which there is a standard for every single vital sign, not just the patient monitor alone, right? For every single one of those. So the accuracy requirement comes from there and it passes through the manufacturer of the medical device in their design validation, ends up in the brand and model specific test procedure from the service manual of the device, in this case, the patient monitor. So we should expect to see the same accuracy requirements in that test procedure as we see in the standards, right? And a couple of us have worked in the medical device side in design and design validation, Doctor. You and I both, right? Okay, so these things become very important to us. So you can see that it's not just the mid-range. The mid-range is fine, but if we're mid-range, we're healthy. Where it becomes critical is too cold or too hot, and the accuracy requirement needs to be met. NIBP. So these are normal, elevated, high, and very high for cuff blood pressure. All right, I'm not going to spend a lot of time on this particular slide. I just want us to reassure ourselves systolic over diastolic is what the doctor and the nurse are looking for. And really, when you question them and get down to the detail, they're really worried about the trend of the mean arterial pressure because it tells you a lot more about the patient's underlying clinical problem, and especially when you're tracking your treatment program, right? Whatever your treatment was supposed to be. Is the trend of cuff blood pressure where we need it to be? Is it trending up or is it trending lower over hours and days, not instantaneously with each measurement? Usually, clinically, that's what we're looking for. All right. That said, we need to test for accuracy. And this is a poll question for you. What is the answer that you think is the best one for how should we be testing NIBP accuracy? Should we be doing a static pressure test or a series of them, doing dynamic simulation, or by performing a visual inspection? God forbid we hook ourselves up and assume that ourselves are in any way, we know in any way whether we're accurate or not. What is our blood pressure at any given time? What do you think the answer is? Probably. That's probably a good answer. A good answer. We'll dig into that just a little bit more in a minute. Anybody have any other idea? B, by doing dynamic simulation. And here's the problem with dynamic simulation. And this was caught and commented by the Organization for Legal Metrology, which is all about accuracy under SI units. All right, we're talking about metrology now. They said there's too many variables and you're not able to control all the variables at the same time in dynamic simulation. Is it good? Yeah. Well, what they said is, yeah, it's good, but it only tells you about repeatability. So let's say you send the monitor a dynamic NIBP simulation of 120/80. Whatever the monitor displays, because it's not about accuracy now, whatever it displays, as long as it displays those same values every time you send 120/80, the measurement is repeatable. And that's all we can say about it. We cannot comment or assess accuracy because there's too many variables. We're not controlling the testing situation. So the answer is we have to do a series of static pressure level tests in order to determine accuracy. And that could include the cuff and hose wrapped around a mandrel or something solid so that we can pump it up to specific pressures. Now, it means the system has to hold pressure, right? So you're going to do a leak test first to make sure you can hold pressure. And then the safety part of testing for NIBP has to do with the automatic and effective release of the opening of the relief valve, so that the patient's arm and tissue doesn't get damaged because of a cuff that gets too tight and stays too tight. All right, so we do a leak test, pressure relief test, and now we're ready to do a series of static pressure level tests. And so we want to test through the whole range. How many test points is up to the manufacturer and the manufacturer's brand and model specific test procedure. If we have to write our own test procedure, we want enough static pressure level test points to make sure that we have linearity across the range of the measurement. And then we may, after we do that, now we'll do the dynamic simulation, assess the repeatability, and everything should be a lot closer and more within our expectation about what we see displayed on the monitor. All right, so a couple of things you should remember about NIBP. The majority of NIBP is oscillometric deflationary, which means it pumps up the cuff just like you would if you're going to auscultate the pressure, going to listen for cuff sounds, and closes off the vessel. And then step by step, it comes down stepwise until we see what is the peak pulsatil pressure in the cuff. And that's called the mean arterial pressure. And then at that point, then there's a calculation that happens either based on calculus, point slope, a series of point slopes, or a statistical analysis of the other pressures as we deflate in the cuff. The problem is, what is the percentage left or right of mean arterial? Do we have control over that? No. The manufacturer, in the model of NIBP that they have installed in this monitor, is the only ones that are in control of that. It's built into their software. We're not in control of that. So if the peak pressure in the cuff is not really the peak pressure, it's a pressure that the monitor has said, yep, that's peak pressure. Now we have in accuracy, potentially, we have a problem with how what the measurement is going to be and what it is that's going to get displayed, right? And that's part of picking the right pressure in the cuff. Well, what can cause problems in picking that pressure? Patient movement of any kind, talking, believe it or not, okay? Shivering when a patient is recovering from anesthesia, or when they're hypothermic and they're beginning to warm up, they're shivering. Crossing their legs, right, exactly. All of these things change the dynamic and make it hard for the algorithm in the patient monitor to properly make the measurement and display the right pressure. Therefore, an important reason to do the repeatability test, but after you've done the accuracy. Leak test, pressure relief, accuracy, and the static pressure level comparisons. Any questions, any other observations about NIBP? I'm going to throw a clinical situation at you and see kind of what you think. In my own experience, more than once, in fact, many times, I've had a clinician give me an urgent call from the clinical unit and telling me this cuff blood pressure is wrong. All right, okay, so I respond, I go up there and I say, okay, tell me more about wrong. How do you assess wrong? Well, it's just not what I auscultated. Okay, how did you auscultate the pressure? Well, I put another cuff on the opposite limb and put my stethoscope on the artery, and I listened, and it was different. If you have taken anatomy and physiology, you know that the pressure on either side is different by definition. It's different moment to moment. So I've had other clinicians that said, after the monitor was done, I repeated the test with another cuff on the same limb, but now it's at a different time. It's not the same measurement. It's a different measurement with a different result. Okay, so what should I do? Anybody had those experiences? Tell me what you did. What was the experience? Can you describe it? Speak up, please.
So I'll say, in most instances, it's like that, but they take a reading with the monitor and they say, well, I didn't like that reading, so I did it manually, and it's lower. Usually, I'll go through the things and make sure they had the right cuff size. I may even test to make sure there aren't any leaks or anything in place.
Good. All good. All good. Keep going.
Then I have some of them, if they're pretty consistent, I will explain there's an algorithm and it's doing it on the steps, and how what you doing it and listening and slowly doing it's going to be different than the machine stepping it down, and that's going to cause some differences.
It absolutely will, and here's why. When you auscultate blood pressure using the Korotkov sounds, all right, you are listening. The Korotkov sounds tell you systolic and diastolic, and you calculate manually the mean arterial pressure. It's exactly the opposite from the oscillometric algorithm to begin with. What's your hand, eye, ear, hand coordination like? What's your hearing like? I had a blood bank manager who took blood pressures every time a patient came in to give blood, and invariably that blood bank manager got terrible readings. She couldn't hear worth a lick. And that was the source of the problem. The monitors were okay, but everything you said was fine. The other thing that I do, and I have done repeatedly, is I have that doctor or nurse on the next regular pressure measurement for the patient, unless they're willing to do an extra one, to put their stethoscope on the artery while the NIBP, while the monitor measures the NIBP, and ask them to listen for the Korotkov sounds and see what they come up with. Invariably, there may be a difference, but it's insignificant. Invariably. Okay. And if there is a significant difference, then fine. Then we'll remove that monitor from clinical use, replace it with another one temporarily, and we'll do deeper dive troubleshooting, which is going to be back to the static pressure levels and make sure it's all working well. Right? Anybody else have an experience they want to share? You guys and gals, come on. This is interactive. It's not Professor Jerry or Dr. Mike. Okay. I mean, we have tons of experience, but all of you have had too, right? Okay, in the interest of time, the static pressure test assesses accuracy and the dynamic test repeatability. So if you get that in your mind, you will have it right. And I gotta be honest with you, full disclosure, I had it wrong for most of my career. Thinking that dynamic simulation told me everything I needed to know about the NIBP and its accuracy. But as we have commented, it actually doesn't. It only can tell us about repeatability. Invasive blood pressure. What's been your experience with issues with invasive blood pressure? Because today, especially here in the US, we have single patient use disposable transducers to turn the pressure signal in the bloodstream into an electrical signal that we can use to display on the monitor. What's been your experience with problems with IBP? Anybody? Level of the transducer is critical because if it's too high or too low, the pressure measurement changes. That's laws of physics, by the way. Right? Who had physics in their academic background before they started being a biomed? 2, 3, 4. Good. You should have. And if you don't, please go backfill that thing. Okay? And human anatomy and physiology, and perhaps biochem too. All right? Those are like really foundational to everything that we do. So yeah, it has a lot to do with the level of the transducer. It should be at approximately the level of the heart is where it needs to be. And then we're going to run the tubing or whatever to make the measurement. It is, I would say, a rather invasive measurement because you're using a catheter and a needle to go into a blood vessel, whether it's arterial blood or whether it's a venous blood, right? Venous blood pressure, or we could have a situation like Dr. Mike, who had traumatic brain incident. The pressure in the skull is going to rise, and in order to make and monitor that and make sure that we try our best to keep it so it doesn't do damage or minimizes the damage, because it's going to do something, there's a cranial bolt that gets installed. It's a transducer, a pressure transducer, but it screws into the skull. And we make the measurement from there, directly on the pressure in the brain. Okay. Now, you don't see that a lot. You're going to see it more in paramedics and emergency care use than you will see it anywhere else. But there are times where we need to keep that bolt in place for several days and monitor that patient. Even though they're not going to spend all that time in the ER, they're going to be moved to a higher acuity room, and we're going to have to do special care on them, right? So, but that's just going to be wherever the bolt is placed. It's a little bit different than the other transducer level. Anything else? Any other experiences with IBP? Okay, gang, participate. You've got experiences. SpO2. Let's look at the fundamentals of SpO2. Pulse oximetry uses two wavelengths of light, red and infrared. It needs a pulsatile signal in order to give us a pulse rate. And it's critical to the fundamental measurement, the algorithms that are in place to actually measure the pulse ox, the oxygen saturation level in the hemoglobin. So it is compared back usually against our arterial blood gases, which are really PO2, partial pressure of O2, which is a little bit different measurement than the percent of oxygen saturation, SaO2, arterial oxygenation. Okay, it's a little bit different. And so there can be some variances. What we're really worried about with this measurement in a vital signs monitor is desaturation. So we would love to see everybody be 100 or 98, 99% saturated. The hemoglobin's nice and full of real oxygen. And there's a little bit of a problem there we'll talk about in a minute. And then if we compare that back against blood gas, oxygen saturation, now we have a way to kind of track and trend kind of what's going on with a rather non-invasive measurement with the pulse oximeter. All right, but there are some things that can go wrong with this. We're making so we've called this clinically in the past hands, toes, ears, or nose. It's really forehead these days. And there are actually two different kinds of sensors. There's the typical, like this one is showing, absorption sensors, where we're seeing what's left over, what has not been absorbed in terms of the light passing through a nail bed, for example, or the earlobe, or the toes or the foot of a baby, all right? And that's called absorption technology, and that's great. But the forehead is a special measurement that we would like to use more in trauma, and anytime we have a problem with the perfusion of the blood or peripheral vascular shutdown, right? Because the vessel here in the forehead stays open longer. Why? Physiologically, to feed the brain, make sure the brain has oxygen, even if other parts of the body don't. But that uses reflectance sensors. So it's bouncing a light signal off the tissue. We're still looking for pulsation in order for us to assess that. But those are the two different types of sensors. And it's important to remember that when we're thinking about, is this vital sign parameter measuring well? What are the things that could go wrong with the sensor? And we've already commented that it is the sensors and the connections on the patient that are going to fail first and most often. So we need to know when it's time to just go replace the sensor first and see if that solves the problem. Take the bad sensor or the bad extension cable, cut them take them with you away from the clinical unit. Vincent, you've had some experience with this. Can you share your experience? Because otherwise what happens? They try and reuse it. And then in 5 minutes after you get back to the shop, another complaint from the floor. It's the same sensor, but on a different patient and a different monitor. Yeah, so make sure with these kinds of things, you take away the bad thing and don't leave it where people are gonna try and reuse it, because they will. Because what they're thinking about is the patient and what they need to do to help that patient get well right now. They're not worried about the technology. They assume you have taken care of the technology, right? Okay, so that's what's happening here. So I don't want to go to rainbow yet. So the way that the algorithms work is when you're doing design validation and getting your clearance to market from the US FDA, for sure, from the US FDA, you have to provide breathe down studies that show healthy volunteers who have agreed to allow themselves to be deprived of oxygen, and then make the measurements and see what happens. So we see the desaturation that happens. The result of that is the raw response curve, or R curve. We then further do more clinical studies on a bigger range of patients, comparing their O2 saturation from the about to be released or released product, medical device, in the field. And those studies and their results are combined with the breathe down studies and result in the final R curve, and that's built into the software of the oximeter that is installed in the patient monitor. And each brand and model of oximeter has typically a different R curve. Big differences, little differences. I think our findings over the years have shown that if you have that the Nellcore oximeters seem to track very well, and that's just been my personal experience. I don't have as much experience overall with Masimo or other sensors that are tried to be used with a Masimo oximeter, the Masimo SET technology. But in general, the Nellcore seem to have a very similar response curve. Right, so when you're going to do the testing on this, you don't have human blood that's going to biochemically mimic what's going on with any other patient in the world. You don't have that. You have a functional tester that is got built into it one way or another, a way to interact with the oximeter and the patient monitor so that you get a specific reading based on the R curve of that brand and model of oximeter. Okay, because the space labs will be different R curve than the Nellcore or the Masimo, and that's not the only oximeters in the world. And our purchasing departments in our medical facilities do a great job trying to drive costs down by buying the least expensive oximeter sensors they can find, and not doing a really big job, or even including us as biomeds, to help figure out whether there was an adequate validation of the design of this alternative sensor so that it's going to work with their claim that, oh yeah, that will work with Nellcore. Oh yeah, that will work with Masimo. It may not, or it may not work well. All right, so what are you going to do? You should be able to know that the R curve that that is going to be used to respond as the simulation of this finger, which is thick or not, dark pigmentation or not, shielded from fluorescent lighting interference or not, all right? You need to be able to simulate that, but it's got to be based on the proper R curve. And so when you do that, you only have the 2 wavelengths of light here, all right? Those are the things that typically are going to go wrong. It's either going to be an off-brand sensor because somebody's trying to save money, or it could be that the sensor is just been used too long. Now we have that problem here in the United States, all across the United States, but we have it really, really more acutely in emerging market countries where single patient use stuff is too expensive. And so they will try and reuse and reuse and reuse, clean or not. Right, so you're gonna see more problems there than you will here. But those are some of the things that can go wrong. Pulse oximetry cannot tell you when the hemoglobin is filled with carbon monoxide. And the hemoglobin will prefer the carbon monoxide. It'll let those in and fill the boxcars, the hemoglobin molecules, and the patient is going to become asphyxiated. They will not be getting oxygen, and therefore they'll begin to die from periphery in. So it's really important that we be able to do that. Well, wonderfully, Masimo, as far as I know, still the only ones, I could be wrong, came up with the need for more wavelengths of light to be used. So Masimo Rainbow uses 8 wavelengths of light, not just 2. Does it give you SpO2, O2 saturation? Yes, but in addition, it gives you more. It helps you know what is filling, what could be filling the hemoglobin itself. Now, when I say that, I mean in the simulation, it will mimic what would happen if something other than oxygen is filling that hemoglobin and cause the patient monitor display to show appropriately and accordingly what's going on. 8 wavelengths of light are required in order to make that happen. Okay, and it will tell you all the different ones. But you can't make that simulation work with a clinical sensor. You need a test sensor. And who makes that? Masimo makes that. We work with Masimo, we do, our company does, to help make sure that there's an adequate functional test of the Rainbow Co-Oximetry. So this is not just oximetry, it is pulsed co-oximetry, and it was the first non-invasive co-oximeter kind of of measurement, the first. Now, I'm not saying it's the only. I don't know that it's the only these days. It's been a while since Rainbow was released. But you need to be able to assess that in any monitor that includes Masimo Rainbow. And typically, you're going to find those in ambulance services because they have to treat for carbon monoxide. They need to identify that early so that they can remove the patient from the non-oxygen rich location to a place where they can administer oxygen therapy. All right, and over a few days, that will help the patient recover, right? So that they don't asphyxiate because they're not getting oxygen to their system. All right, so you're going to need a way to assess that, and you should be looking at your inventory and monitoring your inventory for the addition of this vital sign parameter, pulsed co-oximetry, and I'm still going to rely heavily on that it comes from Masimo because I don't know any other manufacturers at this moment who are doing anything like that. Other manufacturers of pulse oximetry are doing other things that help accuracy, even in low perfusion patients, in patients with movement, a lot of movement. All of those things can affect what's going on. Any experiences or other questions about oximetry or pulsed co-oximetry? Did you learn something in this part of the session? Yeah, okay, heads nodding. That's a good sign. All right, let's talk about capnography. We don't make any way to simulate capnography. It is a concentration measurement of, in this case, CO2, exhaled CO2. But if you have a respiratory gas monitor, whether it's built into your patient monitor or in addition to the patient monitor that goes maybe with your ventilator, or if you have it built into a multiple gas monitor on an anesthesia system, again, either added to or integrated into it, the way that you make this assessment is with cylinders of certified test gas concentrations. And these are small cylinders. So they're like small propane cylinders that you would use if you're trying to burn off paint or something like that. They're that size, they're small. The difficulty here is that the apnea monitor built into, especially end-tidal CO2 parts of the patient monitor, need to see a breath rate, a repeatable breath rate that makes sense. So the cylinder usually has a valve on top, and you're pressing the valve as repeatably as you can. And sometimes you're going to trip that apnea monitor because it doesn't look right to the assessment based on the algorithm in that particular part of the device. But you're going to use a certified test gas. All right, so I had a different picture. It's probably in our anesthesia system testing deck, but that's what it is. Now you can measure oxygen saturation or carbon dioxide uptake and tidal CO2 using a bifurcated cannula where one nair is receiving oxygen, the other one is taking the exhaled carbon dioxide from the exhalation from the nose. All right, what happens when you have a mouth breather? Somebody who's suffering from sleep apnea, for example. Now you need a mask, and so you're going to sample that off the Y piece here so that you get both the inhalation and the exhalation part. All right, so that's how it can be measured. Things that can go wrong typically can be blockages in the end-tidal CO2 or multiple gas monitor because it's a side stream sample. Now, there's another way to measure exhaled CO2, and that's with a mainstream sensor where there's some mechanicals that are connected right at the Y piece. Okay, and those are all great too. There's a special thing that those manufacturers make that you clip on instead of the patient breathing tube that helps you get to it's a 2-point test to make sure that your capnography is working properly. We don't make those, the manufacturers of the monitor will make those. But mainstream measurements are also there and available. But any other side stream, whether it's microstream or whether it's a higher flow rate, those are all assessed in terms of the gas concentration using those certified test gases. Any other experiences or observations about that? Who's including that as part of their testing of patient monitors? Good, 1, 2. Do the rest of you have CO2 monitoring as part of your patient monitors? A few. Should be in the higher acuity areas, should be in the ER for sure. OR, it's going to be part of the multiple gas monitoring system, but it's going to be there. those are required to be tested also. And if you follow the manufacturer's brand and model specific test procedure from the service manual, you will see capnography as one of the categories of testing that you need to do. Okay. All right, why did I leave ECG testing till late in this presentation? When you do testing on ECG, what are you looking for? Let's think about it for a minute. Can you make any measurements off the display screen of the patient monitor for ECG other than heart rate? Can you? You shouldn't. The patient monitor would have to be placed into diagnostic mode, which is a less filtered signal, so that you don't have anything that's getting in the way of the actual assessment of the arrhythmia, the rhythm of the heart, right? Which is critical to the cardiologist and to cardiovascular surgeons and to anesthesiologists. Those are all important things. So the measurement that we need to make, not just on the monitor screen, but on the strip chart paper as well, is number one, make sure the strip chart paper is spooling at the rate that we think it is. You need a marker and a stopwatch to do that. You don't need anything more than that. Make sure that that's working. Then the next thing you want to do is make sure that when you push the button for a 1 millivolt cal pulse, that on the strip chart paper, you see 1 millivolt in amplitude. And it's that 1 millivolt in amplitude that is actually, besides heart rate, the metrology, the metrological measurement we're looking for. Because anything about the arrhythmia, the rhythm of the heart, the dysrhythmia of the EKG signal is not something we can assess electronically. It needs to be assessed by the cardiologist who is diagnosing the problem. And typically they're going to do that on a 12-lead EKG cart, not on the patient monitor. But thereafter, if the patient has an arrhythmia that they're treating with medications, they're going to do a further assessment on the strip chart paper with calipers about timing and whether they see a P wave or not, or they see an elevation or depression of the ST segment or not, if they see premature contractions or not. Those are not, we can simulate those things, but they are not, they are typically examples, classic textbook examples of those arrhythmias, not coming from the 3 official libraries of cardiologists diagnosed real patients. And in order to get past US FDA, evidence has to be provided that with arrhythmias coming from each of these 3 libraries, that your arrhythmia interpretive system properly calls the arrhythmia. We can't do that you would never be able to afford a test instrument that had that built in, nor could it be very well maintained and sustained. Because you can rent those signals, but you cannot buy them, you cannot incorporate them into your system. It's much more difficult than that. So what is the main thing that we care about? ECG heart rate and that 1 millivolt cal pulse, and that we see the proper speed of the chart paper, because the chart is always diagnostic filtering, the least amount of filtering at all. The patient monitor's default on the screen is not diagnostic, it's normal filtering. To get rid of things like artifact from lights, defibrillator railing the display signal off to the top or bottom of the display screen, things like that. Anybody else's experiences or observations about ECG? Exactly. Cables and electrodes, electrode prep, placement of the electrodes, faulty lead wires or trunk cables. Sometimes those are all built together. You can't separate them, so you would have to replace the entire trunk cable. Those are where the failures are going to happen here, by and large, more than anything else. But the strip chart recorder is also a problem, right? Even though we don't have to lubricate those chart motors anymore, they're permanently lubricated, they still can be messed up. So be sure you're testing the strip chart recorder and make sure that it's spooling at the chart speed that you expect. And by the way, you have at least 2 selectable chart speeds still on most monitors. So make sure that you test both. Test both. And that's how to maintain your accuracy about that. All right, fetal maternal. I'm not going to talk a lot about this. Again, it's mostly about the sensors, things that connect to the mom, things that connect to the baby. So we measure heart rate of the baby using ultrasound, which straps to the mommy's belly, and we pick up the heart rate of the baby. We can hear the heartbeats. That gets converted to a display on the fetal monitor. Then the other way we can measure EKG and heart rate is with a scalp electrode. It's a little screw thing that actually goes in the baby's scalp for when the baby's in real trouble, and we really need a much more direct way of measuring. So make sure that you're testing that part of the system, but those are single patient use, disposable connections to the baby and the mom. The mom is going to get regular ECG electrodes and lead wires. So same problem that we have any other place with those we're going to have. All right. The other things that get measured in fetal monitoring are intrauterine pressure, which could be non-invasive using a TOCO transducer, again, strapped to the mom's abdomen. And it's a pressure transducer that responds and shows us the change in pressure due to the uterine contractions. If we need more specific than that, if we're not satisfied with that clinically, we can use an intrauterine pressure catheter and transducer. Those are also available in another way that can be measured. It's cabling again. The sensors are again typically single patient use and disposable, not intended for many long days, not in this scenario. Mom's going to deliver within the day, typically. Labor can go long in certain circumstances, but they're going to induce labor or they're going to take her to C-section. Okay, just clinically. Cardiac output, we can simulate, but again, it's based on what is the monitor looking for, and then we give it an electronic simulation that it can respond to, and we're looking for specific responses. These are called out by the manufacturer in the brand and model specific test procedure. There are specific accessories that you need in order to connect to your simulator, including ours, and connect to the patient monitor for cardiac output. And it is based on the thermal dilution type of cardiac output, not any other way of measuring cardiac output, because there's 2 or 3 other ways you can get an assessment, but those sensors are very expensive and are less typically used or found. Okay. Q&A, quickly. How long do we have, Kennedy? A little bit more time? Okay. Questions? experiences. Talk to me. I want to hear. This is where I learn from you, okay? It's where I learn from you. So what's been your experience? What happens when you go out to do these tests? You're only going out once a year, right? Once a year. Once a year to each clinical unit where you have patient monitors. Typically, I don't think you assign patient monitor testing. Charlie, go. And Charlie's going to spend the whole rest of the year testing patient monitors because the hospital's big and there's a lot of them. No, probably it's more of a clinical unit assignment that you're going to do. I get it. But what's been your experience? Come on, guys.
Just going back to Maximo rainbows.
Uh-huh. Uh-huh.
I remember just getting stationed at
Uh-huh.
fire trucks and taking my simulator, plugging in like, is it fight at all?
No, it won't. It simply won't. And one way or another, you have to have that special test sensor, and then it'll work, because all of the pulse oximeter simulators, ours and everybody else's, are red and infrared only, not the full 8 wavelengths of light. And so that test sensor helps that problem a little bit. But yeah, I mean, that's a perfect example. And why would that be? Because the ambulances, the fire trucks, are going to a smoky place. And the victims are going to be both the people that were in that place plus the firefighters when it comes to smoke inhalation and carbon monoxide poisoning. Yeah, exactly. Exactly. Well, I hope I have teased up in your mind some things to think about. I really would have appreciated a little more coming back from y'all, because you do this testing more often than I do these days. Anything else is still appropriate for a minute or two. Any other experience? Yeah. Uh-huh. Because they provide the bright light that's needed to be able for the clinician to be able to see and assess changes in skin coloration that can be due to asphyxia or hypoxia, where we get blue because we don't have enough oxygen, and the like, when we're trying to assess abrasions and wounds and whether they're healing properly. It was much worse when pulse oximetry first came into clinical use. And the trick that I learned from an anesthesiologist was the little package that you take the reusable sensor clip out of, it's usually has some foil around it. They clip the sensor onto the patient's finger or toe, and then put that package over the top, because in the early days, interference from the lighting, the 50 hertz interference of the especially fluorescent tubes, was causing interference that was picked up and displayed and interfering with the actual signal from the patient. Now, today, much, much less so. There is a lot more signal rejection filtration that happens in the designs of oximeters today than ever before, but it still can happen. And 50 hertz or 60 hertz interference can couple into ECG, where one lead is like pulling away, and so now the signal has an entry point and it will couple in, and that's where your common mode rejection ratio of the patient monitor should have been helping, but now your common mode is interfered with because you have this one errant lead that's allowing that signal to come in, but none of the other ones are. So now you don't have a common mode anymore. It's not in common, it's separate. And so it couples through and gets displayed on the monitor. So you see the hashiness on, and you can't read the QRS because of it. And again, much worse in the old days than these days. Okay, thank you all for coming and for participating today. Don't forget to scan the QR code so you get your CEU credit, especially if you have a CBET or certification and are trying to keep current. You really need that. And by the way, when we do these online, so watch for our events, get on our list, our contact list, you'll get a CEU credit from ABNC every time we do these, or if you look at our archive of webinars, you'll also be able to get that CEU credit. So collect them, do yourself a favor. Again, thank you all.